All right. Okay, so the first topic that we have included is pneumonia. This is a very commonly tested topic, and antibiotics of which are pretty straightforward if one gets used to it. So the first one that you need to understand is that pneumonia should be categorized, right? Whenever we are dealing with pneumonia, we need to categorize it into several groups. The first one is an outpatient community-acquired pneumonia. When we categorize into different groups, that is when we can decide which management plan do we need to go for. As a general rule, when you have got a more severe infection, you use broader spectrum antibiotics. And when you have got a milder infection, you generally go for the simple antibiotics. This is the general rule that will span across all conditions. So for the outpatient cap, the treatment of choice is between a beta-lactam antibiotic, that is amoxicillin. It's a simple, straightforward drug. Now, this amoxicillin, there is noise from somebody's mic. They can close it. So amoxicillin is the first line. Other than that, we have got the option of doxycycline and azithromycin. Now, what we need to understand is generally there was an initial concept of azithromycin being prescribed alone as a single drug of choice, but over time the resistance has increased. So what we generally go for is a beta-lactam antibiotic plus azithromycin. This is the combination that one should remember. This is the most preferred one, and this is the most commonly used one. And whenever we are going for outpatient therapy or community-acquired pneumonia, this is what we go for. And sometimes they may give you the option of a respiratory fluoroquinolone, which is levofloxacin. There are two respiratory fluoroquinolones. One is levofloxacin, and the other is moxifloxacin. Both have got good gram-positive coverage. When we talk about pneumonia, we need to know that it is streptococcus pneumonia being the most common, right? So we have to cover for that gram-positive organism. And the reason why we have this azithromycin here, this is because of the atypical organisms, the ones, for example, mycoplasma and other atypicals. Those intracellular organisms, they are best covered with azithromycin. So this is where the effect comes from. So whenever you're trying to understand the topics, antibiotics, dealing with the pathophysiology, understanding the etiology, that can help you remember those antibiotics, because if you generally know the coverage of, we don't need to know the exact coverage of all antibiotics. That will be difficult, but a general idea of, for example, amoxicillin being a gram-positive coverage for starters, that is where it starts. Now, levofloxacin has got good, is a broader spectrum one, good gram-positive glutamin. This is why it is used as an isolated or monotherapy drug. So this is another option, right? The next one, we have got inpatient community-acquired pneumonia. And whenever we have got inpatient, it means that the severity of the infection has gone up. That is why we have to treat them as inpatients. Now, same as 2, 3 as I have written, but with the fact that we better shift to IV drugs instead of oral drugs. So what we do is that we generally go for an IV beta-lactam, such as ceftriaxone or ampicillin sulbactam. These are two most commonly prescribed beta-lactams that we give, and this is why we have included them here. The next one, ICU, and then I've added hospital and ventilator acquired with that as well. Now, this is something that we need to understand in pneumonia. So far, the management was straightforward, but whenever we have got an ICU level admission or a nosocomial infection or a ventilator associated infection, uh, we always consider for two organisms. And these organisms, once you understand the coverage of this, it will help you across all topics. One is Pseudomonas and the other is MRSA. We need to understand what antibiotics can cover for Pseudomonas, and we need to understand what antibiotics can cover for MRSA. And anytime there's a severe infection, anytime there's a hospital-acquired infection, we do look for covering these organisms. Now, there is a lot of ongoing controversy about whether we go for both of these coverage in all of the cases, but this is something not relevant to us. When it is asked in the board exams, it will always be expected that you know of this coverage. So pseudomonal, I have given only 3 examples here, which is cefepime, piperacillin, and piperacillin tazobactam is one drug. So those those 2 examples. Along with that, you need to know the other pseudomonal coverage. You can have mnemonics from the internet for that, but there are around 7 to 8 drugs easily that can cover for pseudomonas. And those are drugs you should remember, because anytime you have to consider a pseudomonal coverage, if you remember those drugs, you will be be able to do that. And MRSA coverage is again limited to some drugs. Generally, we go for the better ones such as vancomycin or linezolid. Other than that, we have got the option of clindamycin and a few other drugs, but this is the most primarily these are the most primarily used drugs, vancomycin and linezolid. So one should always understand these two organisms, and we will see how it helps across a lot of other infections. So whenever we have got ICU, we consider this coverage. We add this coverage basically, and with hospital acquired and ventilator acquired, we go for the same things. So let's move forward. This was pretty much about pneumonia, which is the lower respiratory tract infection. There's a few more important key concepts. The first one is being aspiration. Now, for a long period of time, it was thought that aspiration is more commonly involves anaerobes. But recently, gram positives have increased in prevalence in aspiration pneumonia. So what we now generally treat it as the latest guidelines, we do not include anaerobic coverage in routine aspiration pneumonia. This is something that one should understand because they will give you an option whenever they are asking for coverage of aspiration pneumonia, simple aspiration pneumonia. They will give you an option of anaerobic coverage. So we do not have to go for that. We simply treat it as community-acquired pneumonia, the same drugs. So the same drugs will be marked as the right option. But what happens when there is a lung abscess or an empyema as well? Then you have to go for the anaerobic coverage. And this is where ampicillin sulbactam is the drug of choice, preferentially the first-line treatment. This is something that they ask commonly, and you will see this across your questions as well, because there are other antibiotics, for example, clindamycin is there, and there are other anaerobic coverage drugs as well. But this is something that the ampicillin sulbactam is the preferred one. So this is what they go for. And so for anaerobic coverage, for starters, you need to know some drugs as well. Ampicillin sulbactam, we have covered through an aspiration pneumonia, lung abscess. So this is something that we should remember. Clindamycin is a good anaerobic coverage. Meningitis has got good anaerobic coverage. We have got more gram-negative covering drugs like meropenem having good gram-negative anaerobic coverage. So anaerobic coverage is also something you will see pretty much in all pyogenic infections or abscesses whenever they have got predominance of anaerobes. Let's move on from pneumonia. We have got one more thing, pneumocystis pneumonia. Yes, this is an exception because this is a viral pneumonia that is seen with the immunodeficiency, right? So whenever you have got pneumocystis, not viral, sorry, whenever you've got pneumocystis infection, the TMP-SMX is the drug of choice. Here, I would like to highlight an important point as well, that when we talk about treatment and prophylaxis of a lot of conditions, we will see that the drug of choice remains the same for those two indications. So such is the case for pneumocystis as well. When we talk about its prophylaxis, the drug of choice is TMP-SMX. When we talk about its treatment, the drug of choice is TMP-SMX. We will see that across other organisms as well. So this is something that they like to test, and this is something that we have been learning from step one for a long time. Now, upper respiratory tract infections, I've included this right after pneumonia so that we can just compare the difference. Generally, the infections are mild, right? So we just go for a simple penicillin, simple gram-positive coverage in the form of either amoxicillin or amoxicillin clavulinate. But when the infection severity goes up, right, when we have got epiglottitis, we can consider an IV ceftriaxone. And we can also consider amoxicillin clavulinate if it is a mild form of epiglottitis. Pertussis, this is a special form where azithromycin is the drug of choice. It is different from the other respiratory. You can use azithromycin for other respiratory tract infections as well, but this is not generally preferred. So this includes all your pharyngitis, the general upper respiratory tract infections include your pharyngitis, your laryngitis, sinusitis, all of those things. You will go for this coverage, and this is something that they would ask. Pertussis, azithromycin drug of choice, and also we apply the prophylaxis rule here as well. When we talk about prophylaxis for pertussis, this is something not essentially part of the antibiotics, but I would like to touch on that. Whenever you have got a person with pertussis and they have got any kind of household contacts, the thing about pertussis prophylaxis is that you will give a macrolide antibiotic to all of those individuals, all of those contacts who has got an exposure with a pertussis patient, regardless of their vaccination status. This is the important point. Sometimes they'll give you a vaccinated individual. You should go for regardless of their vaccination status. So every household contact will be given a macrolide antibiotic, right? So that was it about a respiratory infections. Now we have another major infection, the form of meningitis. What do we remember about meningitis? The first thing that we remember is this combination. This combination will pop up many times when you are facing meningitis. The vancomycin plus ceftriaxone. Why do we have this particular combination? We'll be discussing more in detail, but on a general level, vancomycin is giving you that gram-positive coverage against those meningococci, the Streptococcus pneumonia. Ceftriaxone has got this added gram-negative coverage for the gram-negative organisms. There's an age group written here, 1 month till 50 years of age. This is important. 1 month is the upper limit for neonates, right? When we talk about neonatal coverage of organisms, it is always different. It is not just different for meningitis, it is different for any kind of infection. We'll come to that in a very short span of time. 50 years of age is the upper limit. We will use these drugs beyond 50 years of age as well. It is just the upper limit because beyond this, we have to add another drug and we'll come to that. But vancomycin plus ceftriaxone, now this is a common concern that we have because generally we have got this beta lactams for our gram-positive coverage, right? So why do we have to empirically treat meningitis as with vancomycin? So with meningitis, you generally have got penicillin-resistant bacteria. And also because of the fact that beta lactams do not have good penetration inside the CNS tissue, even when they are inflamed, for example, in the form of meningitis. What is this one exception of beta lactam that has got good penetration is this one right here, ceftriaxone. So this is what we are giving here. So vanc plus cef is the combination to remember for meningitis always. Now, what is the question that we need to ask? We need to ask ourselves whether we need to add ampicillin or not. Whenever we have got actually 3 indications. The third one I missed out here. Whenever we have got an immunocompromised individual or an individual with over 50 years of age, or someone who is pregnant. These are 3 indications. Whenever we have got any 3 of these indications, we'll add ampicillin to the combination. Why do we do that? Because we need to cover for an organism called Listeria. This is an organism not covered with this combination of drugs very well. So this is something that you should remember as a very important indication of ampicillin. And the other question that you need to ask, whether we need to replace ceftriaxone with an antipseudomonas. We talked about in pneumonia how pseudomonal coverage is important for severe infections, so nosocomial infections, right? Now here the antipseudomonal that is given is cefepime and meropenem. I have discussed those antipseudomonals with you. So we have got, whenever we have got an immunocompromised status, a nosocomial infection, after trauma or after surgery, these are all possibilities that we can have a pseudomonas infection, a severe infection. So we should replace ceftriaxone, which does not have good pseudomonas coverage, with something that is very good against pseudomonas. So this is something that you need to remember. These are the 2 questions you should ask yourself whenever you're dealing with meningitis, whether to add ampicillin or whether to replace ceftriaxone with an antipseudomonal. Now, we talked about less than 1 month of age being very different, a very different age group. So this is the ampicillin plus gentamicin combination for neonatal sepsis. I've written the term neonatal sepsis because this is what you will face in your exams. You will not face, for example, you can have a case of neonatal meningitis, you can have a case of neonatal pneumonia, but generally those infections are severe enough to be classified as sepsis. So we just grouped them all together under the umbrella term of neonatal sepsis. And this is also very unique because it will present with symptoms and signs that you will not see in regular infections, right? So when you talk about neonatal sepsis, you can have a baby who is just crying, who is lethargic, who is maybe hypotonic, who has got obviously a low blood pressure, temperature instability. So whenever you have got these signs, and jaundice as well. Jaundice is a very important feature of neonatal sepsis that you should remember. When you have got these signs in a neonate, you suspect neonatal sepsis. And the drug of choice, the combination of choice is ampicillin plus genta. It's as simple as that. You just remember this combination for all forms of neonatal sepsis. This is what we give. It covers essentially all the organisms. Reason we have ampicillin here, we need to cover for an organism called the group B streptococcus or the Streptococcus agalactici. We know how it is a very common cause of neonatal pneumonia, meningitis, sepsis. So this is what we need to cover from ampicillin. Gentamicin will cover those gram negatives. It is a very good aminoglycoside and it works in neonatal infections. So That's what we do. We can add, if the infection is severe enough, we can add two drugs from the cephalosporin group. We can add either a ceftazidime or ceftazidime. Both are third generation, like ceftriaxone, but we do not use ceftriaxone. This is an exception. Ceftriaxone was used in the beyond 1 month of age, but below 1 month it can cause meningitis. So this is what we need to remember about ceftriaxone. This is a very important point about according to neonatal sepsis that we should be familiar with. But the combination of choice, ampicillin plus genta, always. Let's move forward. Let's talk about an abscess in the brain now. We talked about one for pneumonia. So what actually, I'd like to take some feedback here. What do you guys think that how we can treat a brain abscess if it has occurred? What should we do? What antibiotics should we add? If anybody wants to answer in the chat or in the voice. Am I not audible? It's, am I audible or am I not audible? Okay, so yes, Ramsha, you're right. We will do anaerobic coverage. So that is what we do. We just add metronidazole, right? So this is something very common to understand. Whenever you have got abscess, you just give an anaerobic coverage drug and you'll be good to go. The next condition, infective endocarditis, another major infection, right? Uh, Again, all of these infections that we are dealing with, we are dealing as empiric regimens. We should know that we have got cultures and we have got tailored antibiotic therapy once we have that. So that is an obvious thing. This is all empiric regimens. So for infective endocarditis, the question that we need to ask whether we are dealing with a native valve or we are dealing with a prosthetic valve. A native valve, whether it's an acute form of endocarditis, whether it's a subacute form, we always go with the combination VANC plus beta. The drug that they want you to remember for infective endocarditis is vancomycin because it covers the very deadly Staph aureus that will have this major implication in acute bacterial endocarditis, right? So vancomycin is a very good drug for that, and this is the staple drug. Beta lactam, there's a choice. You can go for cephalosporins. There are multiple drugs available. You can go for ceftriaxone, another cefepime, etc. Right? So what you should remember is the combination of VAC plus beta lactam. It's pretty much same as meningitis. This is the fact that meningitis has got this specific indication of ceftriaxone, primarily because ceftriaxone has got a very good penetration to the CNS, unlike other beta lactams, right? So we can add gentamicin too. This is something that you should know. Gentamicin is a drug that we do employ in infective endocarditis. The next thing, prosthetic valves. Prosthetic valve, we have two groups. We have one group that is prosthetic valve endocarditis within the 1 year. If we have that scenario, we're looking at more severe infections, right? More forms of acute infections. So we do add gentamicin and rifampin. These are the two drugs that we always add in prosthetic valves. So rifampin, the reason it works is it works on biofilms. Gentamicin because we just want we want to ensure that excellent coverage against the gram-negative ones. Prosthetic greater than 1 year, we use the same combination as was a native valve, so it does not differ. So this is even when you're dealing with the prosthetic valve, you may be sometimes drawn into that gentamicin rifampin combination. But if it has gone beyond the period of 1 year, we do not go for that. We just do the simple treatment of VANC plus beta. I have included a targeted therapy for HASIC here, not necessarily for other organisms. You can find for other organisms as well, but those are pretty obvious. For HASIC, I specifically mentioned ceftriaxone because we do not have many options for HASIC. When we are dealing with these indications, we deal with certain categories where we have got options of multiple drugs, and not one is necessarily preferred. But for HASIC, because there's a necessary preferred drug, which is ceftriaxone, I have included that. So for HASIC organisms, always remember ceftriaxone. Now, prophylaxis. Infective endocarditis has got a very important topic around of discussion, that is prophylaxis, right? So what do we give for prophylaxis? That's the first question. We either give a single dose of amoxicillin or ampicillin or cefazolin. These are the preferred drugs, and these are given pre-procedural. When we talk about pre-procedural, it is either typically 60 minutes before the procedure for amoxicillin at least and cefazolin. But why pre-procedure? Because we generally go for prophylaxis only in certain procedures, right? What kind of procedures are there? There are ones that we have got wherever we have a gingival manipulation and dental procedures. That's the first one. The second one is whenever we have a GU or GI procedure, bronchoscopy, cystoscopy. The third one, whenever we are dealing with the heart itself, whenever you are going for a pacemaker implantation or an open cardiac surgery, any form of cardiac surgery. The last one being any form of severe skin infection that has pus, any kind of biogenic infection. Whenever you're going for the drainage of that, incision of that, you go for prophylaxis in that. Now, these are the certain procedures that we should include prophylaxis for infective endocarditis, but not in every individual. So you need to understand those two separately. The effective endocarditis prophylaxis is only done in three scenarios. Number one being a previous episode of infective endocarditis. Number two being an unrepaired cyanotic heart defect. And number three being what was the number three? We have got previous episode where it was prosthetic material, prosthetic valve, right? So whenever you have those three situations, only then the pre-procedural prophylaxis is done. So both of these things should be remembered. When to do it, what kind of procedures, and what drugs as well. Now, this is a question that is commonly asked in the exams. They will give you allergy to certain drugs, right? They will give you an allergy to certain drug and they will ask you what to do. So any ideas what should we do whenever there's an allergic reaction to a certain drug in this specific scenario, infective endocarditis, if anyone? So Mahi is saying desensitization. Any other answers? Any other responses at all? Okay, so generally we do not go for desensitization here. We have got an option of doxycycline and azithromycin. So when do we desensitize individuals is that when we have got only a single antibiotic choice for that individual. When we have got multiple choices, we can just simply go for an alternate drug. So this is the situation with infective endocarditis. This is a situation that you should remember because there are not many scenarios where you will be asked about allergic reactions and what to do then. So this is something that we are covering pretty much essentially all of them in our presentation. So for first one that we have come across is infective endocarditis, and whenever there's an allergic reaction, we go for doxycycline or azithromycin. What you need to understand is you need to understand that what form of allergic reaction would warrant a change in antibiotic or would warrant any action. They can give you a mild form of allergic reaction that will not warrant any reaction. For example, if anybody has got a mild rash, a mild cough, it does not indicate that you would go for an alternate antibiotic. You should go for an alternate antibiotic whenever you have got a systemic allergic reaction, whenever you have got an anaphylactic picture, maybe, or a very generalized diffuse pruritic rash, anything like that. So this is something that you should look for whenever you're looking at allergy. What we do in questions is that we are often in such a rush when we are highlighting, we just mark the term allergy and we do not consider anything beyond that. They are sometimes described as mild allergic reactions or maybe described as severe allergic reactions. So this is always a consideration that you should have. Okay, the next one is rheumatic fever. Again, cardiac condition, so we have included that pretty close by. Simple treatment, one treatment, penicillin G. You will not face penicillin G much elsewhere. There's syphilis that you will face it across, but rheumatic fever is the other indication. Intramuscular penicillin G, whenever you have to go for streptococcus eradication, that's the first one. And eradication of the streptococcus bacteria can can prevent rheumatic fever, not resolve. Once the fever is established, the antibiotics will not really help. But once the throat infection is there, we can go for this. And also, the other complication of group-based streptococcal infections, post-streptococcal pulmonary nephritis, that is something that is not prevented with penicillin G. So something you should remember. Prophylaxis is again an important component of rheumatic fever, just like for infective endocarditis. Again, we apply the rule. Treatment, same drug. Prophylaxis, same drug. The same drug rule is that benzathine penicillin G will be used. But we have three groups of prophylaxis. This is where it starts to get complicated. This is where it starts to become a little volatile. But we have to memorize it. This is something that can be asked. Carditis, but we just group into three categories. The first one being the most severe one, where we have got involvement of both the heart and the valves. When we have got both the heart and the valves, we go for till 40 years of age or 10 years of age, whichever one is longer. Obviously, we want a longer coverage, right? So we keep the safe margin. If 10 years is being longer, then we go for that. If 40 years is longer, we go for that. So that is for the most severe form of the disease. Prophylaxis agents are the same. Benzathine penicillin G. The next one, carditis alone, but we do not have valve disease. This becomes the 40 years narrows down to 21. The 10-year span remains the same. Again, the longest. And carditis, no carditis, no valve involvement. This is the least, the mildest infection. Still, we go for 21 or 5 years, right? So this is something that we should do after rheumatic fever to prevent a recurrent infection. So till 21 years or 5 years. So the numbers are they look a little memorizable. If you look at them, 40, 10, 10 are the first two groups, and 40, 21, and 21 are the next two groups. Only the last one has got the 5 years span. So in terms of numbers, it can be remembered. Benzathine penicillin G, drug of choice. Another question again, what if the patient is allergic to benzathine penicillin? And the answer is azithromycin. You remember the previous one? The previous one has got doxycycline or azithromycin. This is something that I wanted to touch upon. I forgot. Penicillin allergy is often covered by these two, doxycycline and azithromycin. So whenever you have to remember, if you have to remember just one cross antibiotic choice that we can give in allergic reactions, penicillin for doxycycline and azithromycin. These three will often have this interplay between them. You will see that later as well. So something we should remember, allergic reactions, azithromycin, right? Lyme disease, an important topic. There are two indications or two different categories. The first one is a mild form of disease or just a skin infection. We go for an oral doxycycline in that. And the next one is, okay, when we have got oral doxycycline, we need to ask two questions, right? This is not just a simple case of allergic possibility, but also the possibility of a pregnant individual. We cannot give doxycycline to pregnant individuals, right? So whenever you have got a teratogenic drug, we should ask, what if the patient is pregnant? So if they are pregnant or allergic, we talked about what? Penicillin, doxycycline, azithromycin having an interplay. So here we go for penicillin. Systemic carditis and neurologic involvement of the Lyme disease warrants an IV ceftriaxone treatment. It is a more severe form of the disease. It is different. It is treated differently. So doxycycline and IV ceftriaxone, two drugs for Lyme disease. Know the indication of each and when to do prophylaxis. Again, an important question that they ask. They will give you a tick bite and they will require whether you should go for prophylaxis or not. So tick, if it is attached for more than 36 hours on your body. If the prophylaxis is being done within 72 hours, there are other two indications as well. All those four indications need to be met together. The reason I did not include the other two was they were pretty obvious. They will either have a very endemic area, something like that. So all those four criteria, if they are met, you will go for prophylaxis of Lyme disease. And the prophylaxis agent, the rule, treatment, agent same. So doxycycline. Simple. Next one is Rocky Mountain spotted fever. Treatment of choice, doxycycline. Whenever we have got these rickettsial chlamydial infections, doxycycline is the preferred agent. The previous one, Lyme disease, was a spirochetal infection. We generally prefer doxycycline. Rocky Mountain spotted fever is a rickettsial infection. We go for doxycycline. So doxycycline is very important with this, especially because this is something that they would give you as a very severe infection. Rocky Mountain spotted fever can present as a very fulminant meningitis, something that you should treat based on clinical suspicion alone without any established diagnostic tests. What if pregnant? The question again for doxycycline that you should ask, still doxycycline. This is something, a rare scenario. Why? Because for an RMSF infection, the only effective drug is doxycycline. When you have got such a severe infection and you have only one option, you cannot do anything. This is why I have put it right after Lyme disease. In Lyme disease, if the patient was pregnant, you just switch to an alternate drug. But in Rocky Mountain spotted fever, you do not switch to an alternate drug. You stick to doxycycline. It can harm the baby, but it needs to first, you need to first consider the maternal health, right? So always doxycycline. This is a contrast that you should remember between RMSF and Lyme disease. The next thing, syphilis. Syphilis, we all have heard penicillin, penicillin, penicillin. All forms of syphilis, we go for penicillin. It's typically an intramuscular form. It's only in the neurosyphilis when we actually go for an IV form, benzyl penicillin G. What if pregnant? Not if it's not pregnant. Sorry, penicillin is not problematic in pregnancy. Sorry, IV benzathine penicillin can have an allergic reaction, right? So pregnancy, whenever you have got pregnancy, you desensitize the patient if the patient has got previous allergic response to penicillin. So if somebody has got severe allergic reaction to penicillin and now they're pregnant, then what should you do? You should desensitize, because like RMSF, because we do not have an option to doxycycline, we do not have an option to penicillin in the syphilis. So we desensitize the patient. This is an indication of desensitization. I've put all these together so you can just compare how these conditions are different from each other. What if the patient is allergic? If it's allergic but not a pregnant individual, if somebody has got an allergic reaction previously but the individual is not pregnant, then you can consider doxycycline. Reason being, doxycycline does have some effectiveness, not as much as penicillin, but in pregnancy we do not want to take the chance of less effectiveness. We do not want the infection being transmitted to the baby, right? So doxycycline is when we can consider only when there is an individual who is not pregnant. So this is something slightly different from the other conditions. STDs, empiric treatment for cervicitis. This is a commonly asked question. Empiric treatment for cervicitis always ceftriaxone and doxycycline. You're basically looking to cover two organisms. The first one is Neisseria gonorrhoeae and the second one is chlamydia. So for Neisseria gonorrhoeae, you will go for ceftriaxone, and for chlamydia, we go for doxycycline. Chlamydia being an intracellular atypical organism. We talked about how those organisms are best covered with doxycycline. So this is the empiric regimen. All patients, you should remember this. Once we have got, because we always take a NAT sample before initiating the antibiotics, right? So once we have got a confirmed infection, we can just narrow it down to one antibiotic based on the sensitivity result, on the culture result. Postpartum endometritis, I've included this here. It's not essentially an STD, but I've just included this here. Is the combination of Clinda and Genta is the classic combination that is used in postpartum endometritis. Slightly different from the combination that we did in neonatal sepsis. It was ampicillin plus Genta, but in postpartum endometritis, we go for Clinda plus Genta. Clinda having that better anaerobic and gram-positive coverage. It also covers MRSA. So Clinda and Genta is the combination. For bacterial vaginosis, Clinda and metronidazole are the two drugs that can be given. Something that needs to be remembered separately. And trichomoniasis, again, being a protozoal disease, and metronidazole covers all those protozoans, right? So trichomoniasis, we always go for metronidazole. Next one is urinary tract infections. Okay, so groups of infections again. You can have lower UTIs, you can have upper UTIs. In lower UTIs, we have got two categories, uncomplicated and complicated. So when we talk about uncomplicated infections, we talk about three drugs primarily being preferred: trimethoprim, sulfamethoxazole, nitrofurantoin, and fosfomycin. Among these drugs, the two first drugs, trimethoprim and nitrofurantoin, those drugs have got certain consideration of pregnancy. The first one, TMP-SMX, is not given in the first and third trimester of pregnancy. One thing we should remember. And nitrofurantoin is not given in the third trimester of pregnancy. They can both have, in the third trimester, they can have adverse effects on the fetus. And the first trimester, trimethoprim can interfere with the folate metabolism, and it can affect it can cause NTDs. So fosfomycin is a safe drug to use in pregnancy. One thing that we should know. And these are the two drugs as well. They can be used in the second trimester of pregnancy. They're not entirely out of the question. Complicated lower UTI. When you talk about complicated, we are talking about a male gender being affected. We're talking about any form of indwelling bodies associated with it. We are talking about any other form of severe infection that is having some complication. So for that, we generally go for a better drug, a more coverage drug, and that is when we consider beta-lactams or fluoroquinolones. So all of these drugs that you're dealing with here, these 5 drugs, TMP, SMX, nitrofurantoin, fosfomycin, beta, all of these drugs are for uterine tract infections. We just need to remember certain indications of them, certain contraindications. For example, we talked about TMP, SMX, and nitrofurantoin being contraindicated in the first and third, nitrofurantoin being only contraindicated in the third one. Fluoroquinolone is something that is contraindicated throughout pregnancy, right? So if I ask you the simple question about pregnancy having a complicated lower UTI, you just go for a beta-lactam antibiotic. We cannot give a fluoroquinolone in pregnancy. Pyelonephritis, it is the same management as complicated lower UTI. It's just that we prefer an IV drug. We just go for IV beta-lactams, ceftriaxone. And also there is one thing that I forgot to touch upon is that nitrofurantoin, the one that you're seeing here. This is one drug that they'd like you to know about. It's not used for upper UTI or pyelonephritis at all because it does not have good concentration in the kidneys. It is only effective for the lower UTIs. All these other drugs that you are seeing, they can be used for upper UTIs. Prostatitis is a special consideration. We can only give drugs that have got good penetration inside the prostate. Those are only 2 out of all of these. The first one being TMP-SMX and the next one being fluoroquinolone. Beyond that, we do not have good penetration for prostatitis, and it's also a longer therapy as compared to other UTIs. Asymptomatic bacteriuria. Okay, asymptomatic bacteriuria. When do we treat this condition? We treat it only when the individual is pregnant. That is the only condition when we treat asymptomatic bacteriuria. Otherwise, we do not, because the complications of them, of these conditions can actually be high in pregnant individuals. It can lead to preterm birth and other complications. The drugs of choice, 3 drugs of choice, we can give all of them. We can give amoxicillin clavulanate, we can give nitrofurantoin, and we can give Syphilis. So it's a milder form. If you look at this, it's pretty much similar to an uncomplicated lower UTI treatment, right? Beta-lactams and nitrofurantoin. And nitrofurantoin we have to avoid in third trimester. DMPSMS is contraindicated in the first and third trimester, something that we have discussed. That covers all the urinary tract infections and asymptomatic bacteriuria. One thing that I forgot to touch upon in pregnancy and pyelonephritis is that whenever you have got pregnancy and you have got either pyelonephritis or asymptomatic bacteriuria being treated, after that the infection is treated, in the remainder of the pregnancy, we go for oral prophylactic drugs. We just keep on the same drugs, we just transition them to oral forms, and we just continue them throughout pregnancy. This is because we do not want recurrent infection. The chances of them being recurrent are very high in pregnancy, right? So this this is the concept that they like to do test in the exams, something that you should be aware of. So even when the infection is over in pregnancy, you go for suppressive prophylactic antibiotics. Bites, there are special scenario. We should go for antibiotic coverage when and with which drugs. We'll come to that. Human, cats, and dogs, 3 kinds of bite wounds that we can come across in questions. The drug of choice is amoxicillin clavulanate. A very simple drug of choice that you should always remember for bites, amoxicillin clavulanate. When do we go for this? Either we are treating the infection, for example, if someone has got a bite and they have got signs of infection, they will give you signs of infection. A wound that is that is just having new erythema, it is having pain, it is worsening. It's a sign of infection. So whenever you have got that, we treat it. But also we treat it prophylactically. So we give this drug prophylactically, even when there is no infection. Whenever you have got 3 situations, we have got either a bite wound on the hands and the feet. These are high risk locations. Whenever you have got a delayed presentation, somebody who has got more than 12, 18 hours after the bite and they have not had treatment for that. And the last one being a puncture wound, because it is a deeper wound, it has more chances of having infection. So prophylaxis of again the rule, treatment and prophylaxis same drug. Amoxicillin clavulanate is given whenever you have got these 3 scenarios, and these 3 scenarios are what you remember. Anti-TB drugs. Latent TB is treated slightly differently from active TB. So we talk about latent TB. We have got a positive screen but a negative chest X-ray TB, as we all know. There are three regimens, and all these three should be remembered because they can give you any of them. We sometimes often remember only one or two, but you should remember all three of them. Isoniazid being the first one, 9 months of monotherapy, that's actually 6 to 9 months. Rifampin being 4 months alone, and isoniazid plus rifampin, the combination obviously takes us shorter time, right? So it's 3 months. So the overall numbers for active TB drugs for latent TB is 3, 4, and 9. So that's what you should remember. Special situations for active TB. The active TB, primarily simple active TB of chest, I have not covered. Those you all remember, the 2 months and the 4 months intensive and continuation phase, right? We have just covered the special scenarios here. For CNS TB, we extend the duration. We extend it up to 12 months. For pregnancy or bone disease, we extend the normal 6 months to 9 months. And finally, there's a special scenario, not tuberculosis, but what about a MAC infection? I've included it here as well. MAC infection is different. We treat it with azithromycin and ethambutol. And what is the prophylaxis of MAC? Azithromycin. Not usually indicated in all scenarios now. We will come to that as well. But the drug remains the same as the treatment. But the treatment has got this addition of ethambutol. So this is a combination that we remember for MAC rather than azithromycin alone. AIDS prophylaxis. These are drugs, antibiotics that we use when we have got AIDS in picture. CD4 count, whenever it is less than 200, we go for TMP-SMS, a very common concept. Now, this is a new concept that we are not aware of often, is that nowadays the CD4 less than 50 is not a routine indication for adding azithromycin for prophylaxis. Because in the recent guidelines, if the patient is on heart therapy, it is alone sufficient. So now they will give you a scenario where they wanted to add azithromycin only when the CD4 is less than 50 and the patient is not on heart. So it is not that you just see the CD4 count and you just see that, okay, we do not add azithromycin anymore. You just mark the investment. It's not always this case. You should always look at whether the patient is on heart therapy or not. Sometimes they may not be on heart and the CD4 count might be less than 50. And that is when you need to add azithromycin for MAC prophylaxis, Mycobacterium avium. And this is something that they test. An antiviral, antifungal prophylaxis. What about that? So this is something that you are not routinely required to do in an AIDS patient. Now, a question comes is that when is antiviral prophylaxis required? Something that you should be aware of as a very important concept. Whenever you have got solid organ transplantation and the patient is on immunosuppressants, this is when CMV prophylaxis should be given in the form of valaganciclovir. And this is separate from AIDS, right? We do not give antiviral prophylaxis in AIDS, but we do give in solid organ. When we talk about antifungal prophylaxis, it's not really there. It may be there in immunosuppressants in solid organ transplantation. We can give it proconazole, and it may be considered in endemic regions where the fungal load is pretty high. In AIDS as well, but not a routine indication. So not something that you should be asked or as something to remember. Febrile neutropenia is a special condition. We talk about febrile neutropenia, we should always consider an antipseudomonal antibiotic. Again, I talked to you about the importance of remembering antipseudomonal antibiotics. Now, if you remember them, you can also remember within those groups, there are antipseudomonal beta-lactams. So obviously, within that group, you'll find certain drugs that are beta-lactams. We generally prefer these in febrile neutropenia because they're also giving you that gram-positive coverage. For example, if we talk about ciprofloxacin, for example, it's also an antipseudomonal drug, but it does not give you that good gram-positive coverage. So when you talk about febrile neutropenia, you need to cover for pseudomonas and you need to cover for those gram-positive. So this beta-lactam, antipseudomonal beta-lactam, is a very effective drug. Burn infection. When you have got burn wound infection or burn wound sepsis, first thing that you should know that in all cases of burns, systemic antibiotics are not required. Prophylactically, we do not give systemic antibiotics. We only give an antibiotic when there are signs of infection. So that's the first thing that you should know. That is something that we are drawn into thinking that maybe we should give them antibiotics, but that's not the case. But when they have got an infection and they have got a superficial infection, we go for simple gram-positive coverage. We go for cefazolin, we go for clindamycin. These are very common drugs for superficial skin infections, soft tissue infections, right? So not necessarily in burn wounds. We'll see that in other, if you have got a case of boil or something like that, we can go for these drugs, superficial infections. Deep. How would you assess for a deep infection? There are ways. Obviously, whenever there's a deep infection, you can have systemic upset. You'll have hypertension, you will have tachycardia, you will have a confused state. All of those signs indicate that the systemic invasion has occurred. And on biopsy, you can have invasion of unburned tissue. What do we do for deep? We talked about those severe infections, meningitis, we talked about pneumonia, we talked about how you need to cover MRSA and Pseudomonas whenever you have got a very severe infection. A deep systemic infection in a burn wound is very severe. We need to empirically treat it for both Pseudomonas and for MRSA. So Miro and Banco is something that I've written here. This is a common drug combination that they employ in burn wound. Miro venom is covering for the Pseudomonas, Banco is covering for the MRSA. Diabetic foot infection right after burns, you can just remember them together. Diabetic foot infections are also involved in that because they are also often involving the Pseudomonas and MRSA organisms. They are severe infections. Okay, now some prophylactic situations. What are those prophylactic situations? In sickle cell disease patients, we have to give amoxicillin daily until the age of 5. It covers encapsulated organisms pretty well, and it is something that you should remember. That's something that they should ask. After splenectomy, what if the person has got a splenectomy? Again, the organism remains the same. Why? Because in sickle cell disease, you have got autosplenectomy. After splenectomy, you have got loss of spleen. So in any case, encapsulated organisms are having a more chance of infecting. So that is when we consider amoxicillin. We consider it for 1 year after splenectomy, but if the patient is immunocompromised, the status expands to lifelong. Uh, for UTI, they also ask you this prophylaxis. They ask you for recurrent UTIs. So first of all, one should know the definition of recurrent UTIs. It is either greater than 3 times per year or greater than 2 times in 6 months. So anybody who has got this number of episodes for urinary tract infection, they are considered to be having recurrent UTI. And for them, the prophylactic options are two. We either go for a continuous prophylaxis, which is simply daily TMP SMX, or we go for post-coital TMP SMX. TMP SMX is the drug of choice. We can go for beta lactams as well. Uh, and that is called as intermittent. So if somebody has got more UTIs in relationship to sexual activity, that is when you should consider post-coital form, or you can consider continuous form. They will never ask you to choose between one or two. They will just ask you to know that you should have these prophylaxis in this scenario, of recurrent UTI. There is a scenario for ampicillin prophylaxis for GBS, intrapartum prophylaxis that we go for. We need to prevent neonatal infection from GBS. We talked about early onset neonatal sepsis being a very common GBS being a very common organism. Group B streptococcus aureus, and we give ampicillin, right? So ampicillin is the drug of choice for that. This is why ampicillin and Genta B was the drug of combination of choice in neonatal sepsis. Now, when do we give ampicillin prophylaxis intrapartum? These are indications that one should remember because this is something that they test. Prior infant with an early onset neonatal sepsis. The important point is early onset. It cannot be a late onset. The early onset are the ones that are transmitted through pregnancy, the first 7 days. Beyond 7 days, pregnancy transfer, the infection is unlikely. The second condition is GBS bacteriuria or a UTI in the current pregnancy. If you have got a GBS positive rectovaginal culture, or we have got 3 scenarios with an unknown GBS, either a preterm baby, all forms of preterm baby warrant intrapartum prophylaxis. If you have got 18 hours or more of membrane rupture, this is the duration that they always give in op scenarios. They will give you that the membranes have been ruptured this many hours ago and this many hours ago. So they might want you to consider prophylaxis. And intrapartum fever, the third indication. So any of those indications are met, you go for prophylaxis intrapartum. And that's it. It was a pretty long lecture. I know it is a lot to take in, but if there are any questions, then you may ask. Any questions from anyone of any sort? You do not have questions? Okay, great. Was any kind of feedback that you would want to give? If it was okay, good for you or not? Okay, so I guess that's it. Thank you so much. It was a pretty long lecture and there's a lot to take in, and it looks very volatile, it looks very messy. But when you're doing it individually, you're trying to remember them all separately, and you're trying to remember it as you. I always talk about the similarities and differences formula for step two. So when you're trying to remember the similarities and differences, and when you're grasping those basic concepts that something does not change. For example, the basic concept that I talked about, a prophylactic agent being the same one as a treatment agent most often. The fact that you need to know about MRSA coverage and pseudomonas coverage and when do we go for those coverage. So all of those are simple points. And once you have those simple points established, you can cover for most infections. You can often look at the options and rule out if you're not remembering the antibiotics straight away. So that's it. There are mnemonics that do exist for these, but not something that I haven't. You will find mnemonics for Syphilis and Prophylaxis. That is something I recommend. Other than that, there may be mnemonics for individual conditions, but I'm not too sure. I have not used them personally. So thank you. That's it. Allah Hafiz, everybody.